Well, good citizens, welcome to another series of evidence-based ophthalmology, and this time it's on Acanthamoeba keratitis. So I thought the best way to start it off is to present a case, and I've got a um, lady in her 50s who is a contact lens wearer, but she only uses it intermittently while she goes swimming, and presented with a 5 to 6 days history of bilateral ocular irritation and red eyes. Initially, the history of contact use wasn't elicited as she did state she doesn't normally wear contact lenses, and she presents with very subtle signs. The image shown here is obviously 3 weeks after her initial presentation, but when she first presented, it looks like ocular surface disorder with simple sort of punctate epithelial erosions and pseudodendritic lesions. Was initially treated as dry eyes and eventually thought it could be virus, and so Acanthamoeba keratitis is commonly mistaken for other conditions like herpes simplex keratitis or shingles related keratitis. But eventually, her cornea got a lot worse, especially in the right eye. So she's into a bilateral disease, but this is the right eye where there's a large epithelial defect centrally, and you can see that all around that defect in the periphery, she's starting to form a early sign of infiltrate. That if this goes on, it would become a ring abscess, and temporarily you could see that there is evidence of perineural infiltrate, and obviously the cornea is quite edematous. The classic signs that you look for include perineural infiltrate, non-specific epithelial defects, pseudodendritic lesions, corneal ring abscess, and corneal infiltrates. By the time you get the classic ring abscess, that's a bit too late. You want to catch it early and treat or commence your therapy before it goes to that stage. And symptoms classically they are more pain, a lot more pain, severe than what it actually looks clinically. Very sensitive to light, photophobia, and watery eyes, blurry vision. And you can see here in this image the actual lesion centrally is causing significant corneal edema. So what exactly is Acanthamoeba? And you can see here, this is a histology of the cornea. Acanthamoeba is a parasite. It comes in 2 stages, an adult stage and a cyst stage. The problem with the disease is that it is so resistant to treatment that most patients will have to be on treatment for at least 6 to 12 months of topical therapy. And you can see over here, I would definitely recommend you go onto the AAO Pathology Atlas website, and you can see the evidence of all the histology. And you can see in this slide here, there's lots of white cells infiltrating into the laminar layers of the cornea, and there's a cyst right in the middle. As you can see that amoebic cyst. Obviously, this cornea is quite scarred up. Now, differential diagnosis includes bacterial keratitis, viral keratitis, fungal, autoimmune keratitis, and chemical injury. So always important to keep it, at the back of your head. You don't routinely miss, viral keratitis or bacterial keratitis, but it's always important to think about Acanthamoeba, especially if they do wear contact lenses, they have poor hygiene, or if they wear their contact lenses to swim in the river and in a hot pool. Those are classic presentation and risk factors. So diagnosis, investigations, you definitely do a corneal scrape for microscopy, staining, and culture sensitivity. You will send corneal PCR, polymerized chain reaction for viruses and Acanthamoeba. Traditionally, we used to culture Acanthamoeba on nutrient-free E. coli plate, where the Acanthamoeba would consume the E. coli as food. But if you do that, make sure you use a new blade. Don't use the same blade that inoculate the Acanthamoeba onto the E. coli plate and then go back on the eyes. You do not want to inoculate E. coli on the cornea. And corneal biopsy in cases of refractory treatment, which you're not sure exactly what you're dealing with. In cases like that, you may sometimes see the actual cyst within the layers of the cornea. And confocal microscopy will be another good investigation. Now, treatment, first line, you would use, toxic medications to try to clean the actual cornea. Pool cleaner is one of those very effective industrial, cleaning agent, which is used as a treatment here. It's called polyhexamethylene biguanide, or in short PHMB, 0.02%. In a lot of places, you've got to get the chemist or the pharmacist to compound it. Chlorhexidine gluconate, 0.02%, is also another one that is available or can be compounded. Brolene is frequently available over the counter for treatment of bacterial conjunctivitis, so it's quite easily accessible. So these are the first line treatment that I would commence on an hourly basis, initially loading those, one drop every 15 minutes or an hour or so, and then do it on an hourly basis for at least 24-48 hours, guided by clinical response. And second line treatment, these are, anti-fungal treatment that you could commence orally, but I wouldn't use it solely as an agent. It's more as an add-on adjuvant treatment for severe cases, or in cases where you haven't had access to any of the first line treatment. Third line includes corneal cross-linking. There is no clinical trials. It's only case series and reports, and they use the Dresden protocol. Amniotic membrane graft would help, with epithelialization, healing, and scarring, and therapeutic penetrating keratoplasty for severe refractory cases or those with corneal perforation, or actual penetrating keratoplasty, say 12-18 months later once the disease is settled down, but with significant corneal scar. That's it, and we'll see you on the next talk.